Good afternoon, respected chairpersons and distinguished members of the audience. I'm very grateful to the organizers for giving me a podium here, an opportunity to discuss with the brilliant minds of medicine and endocrinology in the sister city of Durgapur. I'm from Bardhaman. Probably I'm the one who is missing among all the endocrinologists here, because by training I'm a hepatologist. But then, in this today's world of overlapping concepts, we find that liver and diabetes, liver and endocrinology are not so far apart after all. So, each of you must be seeing patients who are coming with some diagnosis of fatty liver, coming with diagnosis of liver fibrosis, or at least with the FibroScan report in the hand. So what is this concept of liver fibrosis? Why does it happen? Now, liver fibrosis, like anything, like the scarring that we learned in our Robbins pathology, is a response to injury. If you get a scar on your skin, it will end up with fibrosis, scar formation. Similarly, if you injure the liver, you injure the hepatocytes, they're going to release a lot of inflammatory signals, inflammatory molecules. They will recruit a lot of local and distant inflammatory cells. And this inflammatory milieu is going to activate these poor stellate cells, which have no business and which will lie supine and lie asleep. Now, once these stellate cells get activated, they become very virulent. What do they do? They start laying down a lot of collagen fibers and other tissue material inside the liver parenchyma. And this consists mostly of collagens, fibrils, and all these. Some matrix like proteins are also laid down. And this is how a chronic hepatitis, small amount of virus in the liver, with small amount of injury or damage to the hepatocytes. The fat in our hepatocytes in itself causes inflammation. And all this have a common pathway of activating the stellate cells, whereby the fibrotic milieu is laid down in the liver. Now, how do we assess liver fibrosis? Of course, the answer is liver biopsy, right? But liver biopsy is not a homogeneous thing. So this is what it looks like in liver biopsy. What we do is called vector stage. So this is stage 0. This is stage 1. You can see this is the blue ones are the fibrotic tissue. This is nasal striatum stain. You can see a little more fibrosis. You can see the fibrosis is coming from one portal tract to another. So this is called bridging fibrosis. And this is called cirrhosis, where the fibrosis is encircling or nodule at the portal tract and is causing the formation of almost a nodule. So this is what is cirrhosis. Now, as you can see, this is very difficult for a clinician to follow and to interpret it in real life and to make decisions or make sense out of it. Only pathologists who have been specially trained in hepatopathology and GI pathology manage to make sense out of it. There was a study which was done, sorry for the animation error. So what they did was, they took this from the same patient, they took different biopsies from different lobes of the liver and found out that the readings were identical only about 1/3 of the cases. In 1/3 of the cases, even in the same patient, taking biopsies from different parts of the liver gives you different amounts of fibrosis. You have to understand that liver fibrosis is not carcinoma, it's not like pancreatic carcinoma. You take a biopsy from anywhere in the carcinoma, cancer cells. But liver fibrosis is a very chaotic event. Some of the portions of the liver, they are getting more injured, they are getting more fibrosis. Some other parts of the liver, they have got more fibrosis resolution mechanism. So the amount of fibrosis is there is more. So the amount of tissue that you get in liver fibrosis is very small and is not representative of the liver as a whole. So it leads to sampling errors, interobserver variability. If you tell a patient that I need you to undergo liver biopsy, patient says, "No, doctor, have I got liver cancer?" Why does not want me to get a liver biopsy? My son is in the US. He does not want me to get a liver biopsy. So there is poor acceptability of liver biopsy. And of course, even though the chances of complications are less, we do experience some amount of post-biopsy pain, some amount of bleeding in the peritoneum, very rarely perforation of gallbladder, and in very rare cases death. So liver biopsy, although we call it a gold standard, it might at best be called a flawed gold standard. Not only because of the patient, but because as physicians, we are not very comfortable with interpreting liver biopsy. We want something more direct, like AB1C. One value, one report, I take decisions, I can understand it. I know there are different cutoffs, and I can take decisions in my clinic based on that. So if not biopsy, then what? What do we need to assess fat? We do ultrasound. In the FibroScan machine that you all use, that you are all familiar with, there is a parameter called control attenuation parameter, which we use to assess fat. There is something called MRI-PDFF, proton-derived fat fraction. It gives very accurate values of the liver, fat content of the liver. Hepatic inflammation, to be very honest, is something we do not have good markers of. But the crux of today's presentation is assessment of fibrosis without a biopsy. I want to check how much fibrosis is in the liver, but I do not want to get a biopsy done. What are the options available to us? There are two major options. One is blood-based. So serum markers. So what do we have? We have something called API, AST platelet ratio index. Another is called the FibroScan. These are very simple parameters. What do you need? You need ALT, AST. You have got that in your LFT report. You have the patient's age, and you have got the platelet count in your CBC value. So only 1,000 rupees of investigation will give you a FibroScan value. You can calculate the FibroScan value, and it will give you some idea about the amount of fibrosis inside a patient with fatty liver and diabetes. The other thing is something called elastography. So as the name implies, what do we find out? How much elastic the liver is. Elastic measurement. How much elastic the liver is, how much stiff the liver is. By doing this, what we have here for doing this, we have got something called FibroScan. I'll come to FibroScan. We have got 2D shear wave elastography with normal ultrasound machines. And we also have got something called MR elastography. Coming back to the serum-based markers, as I was mentioning, that FibroScan can be calculated with age, ALT, AST, and platelet. What are the cutoffs? After using this formula, if you get a cutoff of less than 1.3, you can safely say that there is no significant fibrosis. And if the cutoff is more than 2.67, you think that, okay, there is a possibility that there is significant fibrosis. Just remember these two values, minus less than 1.3, more than 2.67. And how do we calculate the FibroScan? It's not a problem. Every one of you taking photos, every one of you has got a smartphone, right? So you put in any calculator, any calculator, and they will ask you for the age, the AST, the ALT, and the platelet count. By using this, you get these values. If it is less than 1.3, you will agree. If it is more than 2.67, you think of therapy, you think of FibroScan, or you think of referral to a center where biopsies are done. And the intermediate, if there are no cardiometabolic risk factors like diabetes or elderly age, you can ignore. But if the patient is elderly, if the patient is diabetic, it is better to err on the side of caution and send the patient for further evaluation and consider the intermediate values as significant also. Now let's come to FibroScan. What do we have in a FibroScan? So, have you seen a FibroScan examination being done? How many of you have seen a FibroScan examination being done? Can you raise your hands? Anyone else seen a FibroScan being done? FibroScan? Okay. So FibroScan looks nothing hi-fi science. It just looks like an ultrasonography probe. It looks like this. The difference is in the ultrasound probe, you have got an array of transducers at the tip of the probe. Here you have got like a small circular or small cylindrical probe. So if you look at it like this, what it actually is that in the probe there is a mechanical actuator. What is a mechanical actuator? It is something which gives a sharp tap on the skin or on the abdominal wall. It just